fine. I'm assuming full fine, it'll be better. So if you have to fill out the WRSTC, the medical form, you can take it to your primary care doctor, but as you age and develop medical issues, some of those medical issues may be incompatible with diving, and so it's good to have an evaluation by a physician who's cognizant of those issues. And so I'm just here to say I'm one of them. You don't have to come and see me, but if you have questions, you could feel free to give me a call. I am sort of winding down my practice in August of this year. I'm going to go do another job, because working in the hospital is really tough these days, by the way. It's tough. So I'm still around for the summer, and I'll be there 1 day a week after August. So I want to talk a little bit about COVID, and then we're going to talk about just diving emergencies in general and how we treat them with hyperbarics and what hyperbarics is. Are you guys familiar with hyperbarics? Have you guys been in a hyperbaric chamber ever for any reason? No?
I visited.
Oh, you have, okay. And you visited one? Okay, cool. So for those who are not familiar, I'll talk a little bit more about them today, and you'll learn all about the little nuances of hyperbarics and COVID and insurance and all of that stuff. Where is the microphone? I want to make sure.
So the microphone is the camera.
Oh, okay. So as long as I'm sort of speaking towards that, it should be okay.
And I hope.
Inya, can you hear us?
They can't talk to
Yep.
us.
Oh, they can. Okay. So yay.
Excellent. Thank you.
All right. Excellent. All right. So just a quick overview. We can skip over a lot of this stuff, but what is a coronavirus? So the coronaviruses have been around since before COVID. They were initially developed or initially identified in the 1960s, and they have that structure that we are now all familiar with, the little projections coming out of it. And the corona refers to those little projections that come out of it. It's like a crown, so it's a coronavirus. So they are responsible for the common cold. So if you have a common cold, you may have a coronavirus. So if you go to the hospital, there's these new companies that have these respiratory panels where they'll test you for like 16 different viruses. And coronaviruses are on there, but then COVID's on there too. So it's important because people sometimes don't realize that if you're positive for coronavirus, it may not be COVID. So especially with kids, just keep that in mind. So there have been 3 coronaviruses that have caused pandemics in recent history. We had the initial SARS back in 2002, and then we had MERS back in 2012. That didn't really affect the US that much though, that was more in the Arabian Peninsula. And then we have COVID-19. So what's interesting is that the clinical and the radiographical findings of these diseases are similar. So when we didn't really know what we were doing with COVID, and I mean, in some cases we still don't really know what we're doing with it, but when we really didn't know what we were doing with it back in early 2020, we sort of relied on what we knew from the previous outbreaks and sort of extrapolated everything based on that. And some of it was right, some of it wasn't, and we sort of evolved our knowledge over time. So we all know this now. We have an incubation period, but most people develop symptoms within a couple of weeks of the exposure. And common symptoms, it really depends on the variant, but back in early 2020, we were seeing a lot of fevers, a lot of dry coughing, a lot of shortness of breath. We'll talk about how the diving recommendations have changed in a little bit, but it's all based on the symptoms. So like the variants that came out last year were more like URI, like upper respiratory type symptoms. We weren't seeing the people getting really, really sick and dying like we were seeing 2 and 3 years ago. And then some people have like random symptoms, so you can have like GI stuff, you can have nausea, vomiting, diarrhea. We have the loss of smell and loss of taste that are really bad for some people. And then some people also have really, really bad cardiac symptoms or respiratory symptoms that just don't make any sense at all. So you guys have all had COVID? I heard, yeah, probably. No!
Not me.
Wow, okay, so who hasn't had COVID? Excellent, no bid, no bid. Love it, love it. So people that had COVID early on, they were the ones that were really, really sick. And since then it's become a lot milder, so we're still seeing people that are sick, but they're sick in other ways. Like they're not like ICU level sick, they're more just like chronic sick. And so that poses a whole different issue. So this is what happens when we do CAT scans on someone who has COVID. So the one on the top left is a normal CAT scan, more or less. So your lungs are black, so anything that's black is going to be air-filled tissue. And then as it gets lighter, it's more soft tissue and bones and stuff like that. So the panels B and C and D are just sort of images of people's lungs who have COVID. And what's random is that back in early 2020, a lot of these people didn't really have profound respiratory symptoms. So if you got a lot of junk in your lung, like normally you're coughing and wheezing or whatever, and these people, I remember seeing on Facebook groups, because my primary training is emergency medicine, although I don't work in the ER now, and I would read these ER doctor Facebook pages, and they'd be like, oh yeah, someone came in for appendicitis, and you could see on their CAT scan that their lungs were all junky, and it was COVID. So the CAT scan findings and the X-ray findings didn't really necessarily match up with symptoms, which was one of the problems early on, is that we were having these really profound radiographical abnormalities that didn't really make sense clinically.
Is that what they call the crackle, right? Didn't
So-
they call it like crackle lungs?
Yeah, so it was like, I forgot what they called it, popcorn lung maybe, but it was like, yeah, something like
Yeah,
that.
something crackle.
Yeah.
or-
Oh, it was like ground glass. We saw
Ground
ground
glass.
glass opacities.
Ground glass.
Yeah. So that's just all the crud, like just cruddy stuff in the lung that doesn't, like, it's not a clear pneumonia. Like if you have a pneumonia, there's like a wedge, and it involves an entire lobe of your lung. This is just like scattered gunkiness all over, for lack of a better word. Sometimes we have to use, random words like gunkiness. It's not like a clear-cut, well-defined pneumonia. So these CAT scan changes, they don't always show up right away after the illness. Sometimes they can peak like 10 days into it, and typically they get better over time, but not always. So there are people who, especially a couple of years ago, were having these really profound changes in their lungs for weeks after. And in some cases, in the initial SARS infections, the CAT scan abnormalities were still present for like 6 months after the initial illness. So this is why we have to be careful when we're letting people go back to exercise and go back to work and go to the gym and go diving, is that they, even though they're like physically recovered, they don't really have symptoms, they may still have pretty significant changes in their lungs that you just can't tell on a regular, like, talking back and forth, listening to your lungs level. And
You're seeing a lot more of that with the initial COVID durations than you are with now these later variants.
yeah, so
What's
you're
the
right.
difference, if there is?
So we started seeing, this was the pattern early on,
Yeah.
and then it evolved into cardiac stuff. So like about a year or so ago, we were seeing a lot of people that were having prolonged cardiac symptoms, and that was also weird because they didn't really have bad COVID to start with. They just were having like upper respiratory, like cough and wheezing and whatever. And then they were like really tired, and like a couple of my divers, I actually had to keep them out of the water for about a year because they had like cardiac inflammation. So I sent them to cardiologists and they did cardiac MRIs, and their hearts were just like grossly inflamed. And
This was with later variants.
this was with later variants, yeah, so that's what we're seeing more of now, although we don't see it as much now. Like now, it doesn't seem to be causing that same reactivity in the body. But yeah, it moved from the heart from the lungs to the heart.
And do you think that the vaccination rates help protect people's heart? Is there a correlation there at all?
Everybody that we saw was vaccinated because back then you couldn't come into the hospital. Well, actually, I guess you could, but they were always asking about vaccination status and exposures and stuff. And so, yeah, all of my divers that had problems, they were all vaccinated. They were because they were traveling places, and to leave the U.S. you had to be vaccinated. So when the Caribbean opened up again, probably like in early 2021, a lot of my divers wanted to go out and go places, and they had to show their vaccination cards, but they were symptomatic, and it was cardiac stuff. Like young people, like young 30-year-olds that were running like 10 miles a day.
What are you talking about?
So they were having palpitations, like they were having like rapid heartbeats and yeah, like they weren't necessarily having chest pain, but maybe with exertion. I guess when they would walk down the street, or like I had a couple people that worked on Capitol Hill when they were walking around the buildings underground, they would just get really short of breath and really winded, and they thought it was the lungs. Their lungs were fine. It was totally their hearts. And when I sent them for cardiology workup, they actually had abnormalities in their heart on cardiac imaging, like on cardiac MRIs and stress tests. So, Yeah, it's crazy. It's just like the most random symptoms.
So, but they, in some cases or in most cases, did they sort of gradually resolve?
So they
or
all
not?
got better, but it took a long time. So I had a couple people that were out for about a year. And I still follow one of them and she's better now. But she wears a Fitbit. Like I actually wrote her a letter a few weeks ago for her to get a Fitbit covered by her FSA for her insurance because she's watching her heartbeat really closely because she knows when it goes up, that's a sign that, she may be having problems. But yeah, it took a year, but she got better.
It's not trying to go for a run.
No, it was just walking around her apartment, like just walking around.
And would you
buying
consider
groceries.
her to have like long COVID, or it just happened that this is her lingering
That-
effect of it?
Otherwise, she was fine. Like she didn't have any other symptoms. It was just the heart stuff.
That's a
So.
big system.
Yeah.
It's just-
Oh, yeah.
Yeah, and for a young person to
Yeah.
not be able to do their normal daily
Yeah.
activities,
Yeah.
Yeah. So she got back, and they've all gotten better. They're all back in the water now, but it did take time for a lot of them. So it's not something that just happens overnight, or even in like a week or two.
Wow.
So, yeah, and that's just because of all these long-lasting findings. So yeah, so heart and lung problems can persist longer than we think.
I have a question.
Yeah.
What if you already had a heart problem before you got the COVID? And then after you got the COVID?
Some people did fine, and some people didn't. There's like no rhyme or reason to it. Like some, yeah, it's just how it's like. I think it's more of an immunologic thing, like how your body reacted to it. Some people's bodies reacted really poorly to it, and that's now we know that that's what causes long COVID. We don't really know why, but yeah, some people
So that's
just
like a
have
strength of
really-
the immune system sort of response, like if
or
you're-
your immune system kind of like went into overdrive and sort of attacked
Oh,
itself.
the cytokine
Yeah, the
storm.
cytokine storm. Yeah. And it can be acute, or it can be chronic, or it can be both. So, yeah, it's really weird. And a lot of things in medicine are very clear cut. This is not one of them. And so, people are always like looking to us for answers, and we don't always have the answers because this is one of those
We're
things like
learning as we go.
we're learning as we go, and each variant's a little bit different. It's really, really weird. So back in 2020, people came up with a classification of disease severity, and this is from July of 2020, because we had to have a way to risk stratify people, right? So what does it mean if you have mild COVID, right? So I remember when Donald Trump was hospitalized, he was saying he had mild symptoms, but he was actually pretty sick. He didn't meet criteria for mild, so sorry, it's kind of small up there, but mild is basically no sign of pneumonia. Like if you have any lung findings on an x-ray or a CAT scan, you are by definition not mild COVID anymore. And that has implications for when you go back to diving also. Moderate would be just, pneumonias and fevers, and then more like lingering cough and wheezing and shortness of breath and stuff like that. And then we have the people that were more severe, that were on oxygen and were intubated in the ICUs and all of that. So I think a lot of people didn't really consider that there were objective criteria. People would just be like, oh, I had mild symptoms. What were your symptoms? Oh, I was like coughing and wheezing for like 2 weeks, but I didn't go to the hospital. That's not necessarily mild. And if you had pneumonia, you were by definition no longer mild. So the risk factors for people that have severe disease, it's going to be the extremes of age, obviously, people that have underlying heart and lung disease, people that have high blood pressure, diabetes, obesity, these are all risk factors for severe disease. But fortunately, most people got better. Now, early on, it was really freaky. I remember being at work, and I got referred a patient for hyperbarics. He'd had prostate cancer, and he was having some bleeding when he urinated. And so somebody referred him to me. And I remember I called this guy, and I was like, oh, do you want to make an appointment? And he was like, sure, I'll come in and see you next Monday. And it was like a Thursday. And then he's like, yeah, but I feel like I'm coughing. Like, how do I go to see my primary care doctor? And I was like, oh, yeah, just call them. I'll see you Monday. So like later on that night, he was found unresponsive on his floor, and he died from COVID like that. So people were getting profoundly sick, and I'll never forget that, because like this guy was talking to me on the phone, and like 12 hours later he was dead. I'm like, oh my goodness. But now with the newer variants, people are mostly getting better, and they're getting better pretty quickly. We do have some stragglers, but for the most part, people are getting better. But then we have these long-term symptoms that we are still only learning about. I'm kind of worried about this because, now I'll talk about the public health emergency. Do we have any federal workers here? Any government workers? Okay, so you have federal Blue Cross insurance? Okay, so you've got 10 days to use it for long COVID. If you have long COVID, I'll talk about that in a bit. But the public health emergency ends on May 11, and so that's going to change a lot of things.
So get it now?
Get it now, and if you have federal Blue Cross, so I will tell you, get your packs loaded now, and get your free test now, because it's all going to disappear. I'll have to pay for all of that
So we
in
know
about
it's
10
just Blue
days.
Cross or is it others?
It's going to be everyone.
Everybody's
It's
gonna
not
do
going to
it
be
eventually.
anything to cover it.
Yeah.
Yeah, I mean, federal Blue Cross is a little bit different because since it was a federal public health emergency, the government was basically telling the federal Blue Cross they had to cover everything.
Yeah.
That's an event. I took advantage of that quite a bit, actually. So we had people we talked about, they have like these long-term lung problems, they weren't able to walk around without being fatigued and short of breath, and that's all this long COVID stuff that we're seeing. And then we're having the brain fog and all of the other cognitive things that are much more difficult to assess, but they're out there. So, like, I have a guy now that we're treating with hyperbarics for long COVID, and he's an attorney, and he's just got like wicked brain fog. Like, he can't work. He sees like floaters peripherally, and so we're treating him, hoping to sort of help get rid of it. And I'll talk a little bit later about why we are using hyperbarics for that. So now we have these long complications. Here we go. In one study, only 12% of patients were completely free of symptoms 2 months out. 12%. So a lot of people are having residual symptoms, whether it's fatigue or brain fog or chest pain or palpitations. A lot of people are having symptoms. And I know, like, in medicine, traditionally, like, if we can't test for it and give you a number, it doesn't exist, So unfortunately, this is how medicine has been over the years. And so this has been a problem for long COVID because we don't really have a good way to test for it, and we can't like give you a number and say you have 7.5% of long COVID. It's more subjective.
Like 12% of patients, if you're talking about all people who were,
Yeah.
Wait a minute,
Yeah.
so 100 people that have COVID, including ones that are asymptomatic,
Mhm.
okay?
Well, they were
Of those,
symptomatic.
90% had some kind of symptomatic.
Yeah, so of those who were symptomatic, like 90% had something persistent after the initial stuff got better.
Wow.
But when you think about it, that's what we're hearing. So people are like, oh, my cough got better, but I was tired for a few weeks. Or my fever got better after a couple days, but I lost my sense of smell for like 6 months or something. So it's more common. I think people are like, it's again, because it's subjective, it's not something that we can easily define, so.
But these are symptoms that people reflected that they still felt.
Yes.
Not that there was some hidden thing going on. They just know.
No, so these are just persistent symptoms. So it's more common than you think. And a lot of people have it.
Is
And
that
it
relevant
sucks.
because, for example, with a cold, you have a cold, you get
And then you're
better,
done.
and you're done.
Right. So with long COVID, you get better, the fever goes away, but you may not have your normal energy level back right away. And that's an issue because you may want to go diving because you're like, yo, I'm fully vaccinated, I have my symptoms, I'm not infectious anymore, my test is negative, but you still don't feel great. And so we don't want you diving if you don't feel up to normal because
So I just, you're talking about long COVID.
Yeah. Long COVID. So we don't want you diving if you're still symptomatic after COVID. So, all the data, here it is. Only 65% of people return to their previous level of health in one study. So so it's pretty profound. We don't know what causes it. Maybe reinfection, maybe the immune response is a little bit off in people. People become physically conditioned when they're home with a cold and with COVID. So there's a lot of sort of thoughts about why it might happen. And you can recover. So there's all these, with the federal health emergency, there was a lot of money set aside for medical care for long COVID. Again, I think that's going to disappear. I don't know what's going to happen with that. But all these like long COVID clinics started up. So I know MedStar has one. I think Inova has one as well. And you can go and you can get your physical therapy and your speech therapy and like all the stuff that you need to sort of help you recover. Although I've heard that it doesn't really help everyone that much. So some people found it beneficial, but I mean, there are some people that just still had really profound symptoms after they went through it.
Is there a correlation between getting reinfected and the likelihood of long COVID? Is there?
That's a good question. I don't know that we have that information, because people, people who have only had a single infection are still getting it. That's a really good question, though. I have had people who have had it a couple times who had a lot of symptoms.
They didn't the first time, but the second
Yeah.
time they did. I was wondering if statistically there was any sort of data.
I bet somebody's looked at that. That's a good question. I don't know the answer. All right, so in terms of these long-term effects, so we see a lot of fatigue. A lot of people are fatigued afterwards. And then we see the people having problems breathing, and joint pains are really common one, just like muscle aches and pains. And then like random stuff, like chest pain also, but random stuff like ENT stuff, like ringing in the ears, and then like peripheral visual floaters. There's just some really weird symptoms that come about. And it's probably all just the body just not having a normal immune response to the infection/cure. So we see these abnormalities in the heart and the lungs and the brain on imaging, although not everyone gets imaging. So what does this mean for divers? So again, when I see a diver, you have that medical form, and there's a bunch of, like on the first page, there's like 10 questions that you have to answer, and if you answer yes to any of them, then it's an automatic kick out, and you have to have somebody sign off on the form. The form has changed over time. In early 2020, COVID was an automatic kick out, and then everybody was getting kicked out of their dive club, so nobody could go diving until they saw a doctor. And so now the form has changed. So if you have to fill out the form, make sure that it's the most recent one. Now it's changed to say I have persistent problems with my heart or lungs. So now if you've had COVID, it's not an automatic kick out anymore unless you're having persistent symptoms, which is good. But when I see divers, I worry about certain things. So as we get older, our physiology changes and we don't have the same level of activity that we did when we were in our 20s. And if you are somebody who dives intermittently, you might not know that, you might feel fine and you might be like, oh, I can walk my dogs down the street 3 times a week, whatever. But if you get caught up in a current or something, you might not be able to overcome that. And we know that a significant amount of mortality in divers is because of undertreated or undiagnosed heart disease. So I'm really careful with my divers. Anybody who's basically like not running marathons gets on a treadmill for me, and I do a lot of stress tests. We want to make sure, it's sort of like an executive physical, we want to make sure that you guys are healthy enough to, be in cold water, in currents, running away from sharks, being okay, carrying gear, all of that stuff. So I look at the heart, I look at the lungs. Talked to a guy today that was he's a recreational, I think he's a straight recreational, and he has some lung issues, and so I'm going to bring him in and actually put him on a stationary bike and see how his lungs act in response to exercise. If you have asthma that's triggered by cold or exercise, when you're breathing compressed gases are cold. They're not like warm. And if you have asthma that's triggered by cold, that can actually exacerbate your asthma. And you don't want to be having an asthma attack underwater because nothing good will come out of that. If you have asthma that's triggered by exercise, same thing. You get in a current, you're carrying gear on a boat, that could make your asthma worse as well. So we typically want our asthmatics to go through exercise to prove to us that they're not exercise-induced asthmatics. And we do a lot of history taking. Actually, I had a guy last week who has asthma that is only triggered by drinking carbonated wine.
Oh
So
my God.
I never heard of that. Right, so he can't drink Prosecco. But this he's a tech diver, he goes all over the place, he does cold water, everything, but he cannot drink wine, he can't drink like Prosecco before diving, because it triggers his asthma.
If you want to drink
What do you
one
want
more
to do?
Okay, so you say that, but like the people that I get are people that are like drinking and smoking their weed and all that stuff while they're diving. So you guys are the smart ones. Not everyone's that smart. I have stories. Like smart people are all
Follow-on presentation.
yeah. I have some crazy stories. Like the stuff, the patients that come to see me, I'm just like, you did what? With what? And what? Really? I had a lady get electrocuted, actually, in North Carolina about a year ago. I actually published her case. It was really fascinating. So she was a tech diver. Most of the techies are guys. She was like this, like, really cute, tiny, feminine girl with her nails done and her hair done. Came into my office wearing like 4-inch heels. She was awesome. So she, you know, she's really thin, so she doesn't have a lot of body fat, so she gets cold really easily. So she bought this heated motorcycle shirt online, but it's not a diving specific shirt, it's a motorcycle shirt, but it's rated for, you know, liquid
Rain.
because rain. And like on the label, it shows like a biker like in the rain, and everything's fine. So she wore that, and she had a leak in her dry suit, and water got in, and when she turned on the suit, it started shocking her. Yeah, and she actually aspirated water, seawater, and then so she had like CAT scans like that. She had bad CAT scan findings. She did fine, but yeah. So some craziness can happen when you're diving, and you know we always say, you know, plan your dive and dive your plan. It does not always happen that way. People go out to their, you know, honeymoon resort and take like a 1-day diving class and then think that they can go anywhere, and they end up going to like Socorro or like God knows where, and get problems. So yeah, we see there's a lot of drama. If it can happen, it will happen. It's drama.
I once ran into some people who were talking about burning marijuana before the intake to the compressor to fill up the tanks.
Oh my goodness. That is insane.
Yeah, I decided I'm not going to.
Yeah, let's not do that. Yeah, I had a lady that was like smoking joints between her dives, and then she actually had she had lymphatic decompression illness, and her breast got really big. And it was probably because she didn't even know what she was doing. She was like smoking joints during her surface intervals. And I'm like, and she was walking to the airport like holding onto her breast, like didn't know what was going on. It was like twice the size of her other breast, and it was all like lymphatic DCS. Pretty cool. So yeah, I mean we see some really wild stuff that you would not imagine. But yeah, so I do a lot of treadmill stress testing because we know that cardiac diseases are a common cause of death. And then lung disease is an issue also. So my guy who's allergic to or has asthma from the Prosecco, he actually has little tiny cysts in his lungs. I'm not too worried about him, but if you're somebody that smoked for a long time, or we have new research showing that cannabis actually, because when you smoke from a bong or a joint, you're like inhaling really deeply and you're holding it in your lungs. So as opposed to smoking cigarettes where you're like puffing here and there, but you're not really holding it in your lungs. So the act of smoking cannabis actually causes just as bad lung damage in some studies as smoking cigarettes. It's because it's a different mechanism of how you're smoking it. So, you know, I've got asked about cannabis too. So if you come in, I'm going to be asking you, do you smoke cannabis or do you use cannabis? How do you use it? If you eat edibles, I don't really care. But if you're smoking, then I'll probably want to do a CAT scan or something, or PFTs, looking at your pulmonary function. Because we know over time that cannabis can cause some badness in the lungs. So, and then, yeah, if you have underlying neuromuscular disease, that can sort of complicate the diagnosis of decompression illness. So if you have like multiple sclerosis, or if you had a stroke, or if you have diabetes, that's another issue in itself, but if you have neuropathy for some reason, like say that you have like a pinched nerve in your back, and you have neuropathy, and you know, if you sit for too long, your left leg goes numb. That can mimic the signs of decompression illness, and so you need to be able to know exactly what your baseline symptoms are, because when you end up bent on some random island like in the Caribbean,
That's my normal.
yes, because you're going to have like some random foreign physician who may not speak our language, may not know too much about DCS, and you need to be able to explain, this is my baseline symptom. So we do a lot of neurological examinations just to prove that everyone's normal, or document what's not normal. And yeah, obviously if you've not made a full recovery after COVID, because we know that you might not have normal energy for months or even up to a year, we don't want you diving. just because that just raises your risk of having an increased stress on your heart and your lungs. So we want our divers to be free from any residual COVID symptoms, like anything, okay? So even if you're like 95% better, I don't want you diving just because that's risky. So your body is used to your baseline. When you're not at your baseline, you might sort of overcompensate and think that you can do more than you can, and that can cause problems. So every time there's a report of a diver who dies, it just kills me, because I always want to know, well, I hope that diver had a good medical evaluation and that they had somebody who helped them define their limits. Because a lot of, especially the younger divers, don't necessarily know what their limits are or how to describe their limits to themselves. So yeah, even minor fatigue indicates that you might have problems with your heart or your lungs. And so that's what we look into. So when I see my COVID divers, we talk about what their symptoms were initially, what their symptoms are now. Hopefully they have none. Talk about how they're doing with exercise. I may want my divers to get on a treadmill after COVID, because if you're like, oh, well, I think I'm like 97% there, but I'm not 100%, I'll put you on a treadmill just to quantify it. So I want to know for myself that I can send you off to some remote island and that you'll be safe out there in Indonesia. In Rajampot, where there's like no medical care at all. So again, a lot of cardiac, a lot of pulmonary testing, and then it's really dependent on the patient. So it really depends on what your symptoms were and are in terms of what I'm going to test you for. So these were the initial recommendations back in 2020, because we knew that COVID was so bad back then. Even if you had mild COVID, so even if you had no pneumonia, but you just had like mild coughing that went away after 2 days, you were getting a chest x-ray, you were getting pulmonary function tests, and if you didn't pass those, you were getting even more tests besides that. So we were doing a lot of testing on people a couple of years ago, and that got really cumbersome. I made some good friends in the pulmonary labs at different pulmonary offices, because at Georgetown it's like a 6-week wait for pulmonary function testing. So I would just call
people all over town.
Yes, yeah. So Chevy Chase Pulmonary Associates became my best friends. We're doing a lot of that. So that was 2020. And then again, like we talked about before, the newer variants they're different. They're generally milder overall, and they're less contagious. So we've had a shift in how we work up our COVID divers now. And the current guidelines allow for people who have minimal symptoms just to not have any additional medical workup. So if you just had upper respiratory stuff, like nothing involving productive cough, so pretty much like neck and above. So no productive cough, no wheezing, nothing like that, just a dry cough that went away. You don't need to have a chest x-ray and pulmonary function testing. I'm good with that now. So here are the amended guidelines, and this is as of 2022. So again, mild COVID, mild symptoms with just nothing lower respiratory or cardiac. You don't have to have any additional workup. So that's good. This is good. So again, like we talked about the medical form, how it's evolved over time. This is the initial medical form in 2020. So you can see question 1 is COVID-19. Again, if you check yes to that, it's an automatic kick out, and you can't dive unless you get a doctor to sign off on it. So this is the newer one, but it's important to recognize the difference, because a lot of dive shops have not adopted the newer form. And that's going to mean that you're going to end up having unnecessary workups in some cases. So look at the form carefully. And usually the dive shops are really good about changing the form. If you go to them and say, this is an old form, you need to use this newer form, they don't need to know why. Just be like, this is the newer form.
2022. Wow.
Look for the 2022 form. Yeah,
You can
and then it
also
should be
get
posted.
the forward from Dan.
You can get it from Dan. You can get it online. Yeah, but I find that like a lot of I guess newer divers mostly, they come in with the old form. They don't know the difference, and I have to correct them and give them a new one.
Where does it say 2022?
I cut it off. It's at the top.
It will be on the top? Okay.
Yeah, I believe it's at the top.
Okay, thank you.
Yeah, I'm 90% sure.
I was
it's
gonna
at the
say,
top.
it's probably also in tiny print on the back, on the bottom.
Yeah, that's right.
So as an administrator,
Right.
like when you make administrative forms, you usually do
On
that.
page 3.
Yeah.
And I always tell people, so this is a 3-page form, be honest on it. Usually I spend lots of time talking to my divers before I have them fill the form out. And people lie on these forms all the time. all the time because they want to go diving, right? So I've had people that have had like heart attacks 2 weeks ago come and see me, and they check no to the cardiac box, and I'm like, no, that's not good. You have died. You just had a heart attack. You know, and people are very passionate. Like I had a guy tell me today, like, no one's gonna tell me not to dive. I'm just gonna do it no matter what. I'm like, okay, well that's your life because, I mean, luckily he was okay, but like, we do hear that. Right, I'm like, why are you coming to a doctor if you're just gonna die regardless? I don't know, but people do that. But be honest, you know, people will always ask me if they should check yes to something. And the answer is yes. I mean, if you have the symptom, you should check yes to it. If you check yes, it's not automatically disqualifying. It may look bad if you're checking you have problems with balance. Like I had somebody recently who had vertigo. And so he wanted to know, should he check problems with balance? Because he doesn't have vertigo now, but he had it 6 months ago. And I was like, yeah, please do, because it's gonna be in my note anyway in your chart. It does not mean that I'm gonna disqualify you. You can still dive. I just need to have it documented that we discussed all of this. So another question that I frequently get is, can we do the evaluation online? And the answer is yes and no. So there is a physical examination as part of this. I do need to see you in person and lay hands on you and do all the neurological assessments. If you're somebody who needs additional testing, like somebody that I talked to today needs pulmonary testing, well, I can do his initial visit over Zoom, because I'm gonna have to bring him in person anyway at some point, but initially we can talk over Zoom and I can get the test scheduled, and then once everything is resulted, then I can bring you in. But yeah, you have to come in and see me in person. I get a lot of people who just want to do telehealth, and I'm like, no, not for this, not for this. Another question I get is it covered by health insurance, or how much is it? And it's covered. I mean, I'm like physician at Georgetown. You just put it through your health insurance and it's fine. The one caveat would be if you're a commercial diver, that's always going to be self-pay. Your company's going to pay for it. Scientific divers, you put them through their regular health insurance. And if you have Kaiser, you do not take Kaiser at Georgetown. And I've heard, anybody here have Kaiser?
I have Kaiser,
Okay.
I've never done anything hyperbaric
So
related.
I've heard they're very difficult. So they don't have any hyperbaric physicians at Kaiser Mid-Atlantic, but they will not give you an external referral to come and see me. It's really weird. And my Kaiser divers are generally not too comfortable with their Kaiser primary care doctor signing them off. And so they'll sometimes just come and pay out of pocket.
I was gonna say, I'm doing TMJ care right now out of pocket, because even though 10 years ago I insisted that this was an issue to Kaiser and I tried to fight for it, I didn't get it, and 8 or 10 years later I did. And in most cases, I think Kaiser does a great job.
Yeah.
But there are certain things that they don't do well.
There are, and this is
Mental
one of
health,
them.
hyperbaric, and
So they'll
Yeah.
refer you, so Virginia Hospital Center is a Kaiser facility,
Mhm.
and so if you need hyperbarics, they'll refer you to VHC.
Uh-huh.
But if you need a dive evaluation, they don't know what to do about that. They will just, they'll be like, go to your primary
Yeah.
care. So
Yeah.
that's a weird one. So I always have to ask what your insurance is when people call, because if it's Kaiser, we gotta have another talk about stuff. So yeah, so when you come in and see me, we do a history, we do a physical, we talk about any issues, and then we might make some recommendations for further testing. This is not always a quick process. This can take months to get done sometimes. If you need like pulmonary function test or cardiology consultation because you failed your stress test or something like that, that's not gonna happen overnight. So if you think that you need to have the form signed off, do it in advance. I get a lot of calls on Friday, like, hey, I need this form signed off today because my flight leaves tomorrow. And I'm like, I mean, I try to help, but I can't always. And the summer camps are problems too, because the parents usually take their kids to like urgent care, and then the urgent care won't sign off on it. And so then like 2 days before camp starts, the parents like calling me, can I come into your office? And I'm only there 3 days a week. So I work at the poison center also, so it's always a scramble. So yeah, make the call early, and we'll go from there. So what does my workup entail? So we do a lot of cardiac stuff, like I mentioned before. Do a lot of echoes, a lot of stress tests. You're going to be on the treadmill. I know it's a pain in the butt. You can't eat anything for 4 hours beforehand. And we don't, like a normal cardiac stress test, they take you to a certain level. We pretty much double that for our divers, because we're trying to make sure that you can get through any potential drama that might happen in currents or hazardous marine life or whatever. So we really push you. you're gonna be pretty much running straight uphill. But most of my divers get it done. I've had people that came in, like I've had a couple of people that were like, 400 pounds, type 2 diabetic, high blood pressure, hypertension, like high blood pressure, the whole thing. And they couldn't pass the stress test, but it was really motivating to them. And then like a year later, they came back and they were like, 200 pounds lighter, and they did great. So the stress test can be like a really, really good thing for divers because it really like shows you what your body's capable of doing. So it is great. So for pulmonary stuff, we usually start with a chest x-ray unless you're already known to have an issue, and they'll go straight to a CAT scan. I like doing CAT scans better just because they show a lot, but insurance usually wants you to get a chest x-ray first. So unless there's a reason that I can prove to not have an x-ray, we have to start with that. But luckily you can walk in at Georgetown for the chest x-ray, you don't need an appointment, and then if anything turns up looking wonky, we just get the CAT scan. And then there's these things called PFT. So this is one version of PFT. PFT stands for pulmonary function test, and it's basically a test where you breathe in and out of a machine, like a little box that you see on the screen. And it measures your lung volume. So that measures how much you can take into your lungs, how much you can breathe out in 1 second, or I think it is 1 second. What your lung diffusion capacity is like if you have any diseases, if the walls in your lungs are too thick and gases can't exchange fully. So PFTs are great. And for divers, especially asthmatics, we'll kick it up a notch and we'll do PFTs with exercise. So we'll put you on a stationary bicycle. They don't do it at Georgetown. Well, I think they do, but it's pretty challenging to get. So I send my divers to Hospital Center for this. You go in the basement, they put you on a bicycle, and they do all sorts of crazy testing on you. It's like very, very intense. And they can actually tell if you're deconditioned, if you're not putting forth your best effort, if you actually have a lung issue that's limiting your ability to exercise. So yeah, so this is pretty standard for any asthmatic and also anybody with like long COVID and really COVID who still has trouble breathing. And then, sometimes I'll do other stuff too, but usually it's heart stuff and lung stuff. Probably like 90% of my divers are getting heart and lung tests if I'm ordering anything on them. So the bad news with COVID and diving is that, again, your body's gonna take time to recover. So if you've had COVID, please do not call me and say, oh, I'm still tired, but I think I can dive. I think I can go to Rajan Pot next week. I'm not gonna let you, or I'm not gonna sign your form at least. You're gonna be on your own with that. We don't, it's good to not expect a full recovery right away. You do need to give your body time to recover, and everyone's different. And if your boyfriend or girlfriend or whatever gets better right away, you may not. And that's just how it is, and there's not much that you can do except let your body just do the natural recovery. If you need physical therapy or speech therapy or something, you can go ahead and do that, but it's not like, everybody recovers at the same way at the same time. So you do have to give yourself time. And the testing process can also take time. So when you come in and you get your medical evaluation, sometimes these tests are going to take weeks to get. If you need to see a cardiologist or have a specialized cardiac MRI or something, that can take time. And we may do more testing on you. So we may find something on testing that we need to do a different test because we need to get more details. So it can be pretty detailed. And then I may have to send you for specialist evaluation too, to a cardiologist or a lung specialist or something like that. So basically the bottom line is it takes time. But the good news is that if you've had COVID, it doesn't mean that you can't die. It doesn't mean that you're going to be disqualified forever. Pretty much like almost all of my COVID divers are back to diving. Again, a couple of them took a year, but most of them are back and they're doing fine. And I have them send me pictures and send me kind of vignettes of their trips, and they're all doing fine. No one's had any problems. It's been great. And it's highly likely that you can get a medical clearance over time. So don't let it discourage you. Things that are going to be like, don't dive ever again, are going to be like if you have seizures. If you had brain surgery and now you're on anti-epileptic drugs and you have a seizure. If you have diabetes and it's poorly controlled and you're hypoglycemic a lot. Like there's certain things that we don't let you dive. COVID is not one of them. So I've gotten calls from the Caribbean where people are like, I just had brain surgery and I have a shunt in my brain, but my neurosurgeon says I can dive. And I'm like, no, not good. If you have a seizure underwater, you have a 100% chance of death. So we don't play with that. Yeah, I've had very few. I don't even know if I've had anyone who has not been able to return to diving after COVID. And again, yeah, just some people require a long time out of the water. So there's some things that you can do. So like my lady, my lady recreational diver that had the cardiac issues, she's got her Fitbit. It's good to get a pulse ox. The pulse ox can actually show your oxygen concentration, and it'll also show your heart rate. So a couple years ago, I was having a lot of my divers wear pulse oxes. You can just get them at Walgreens. And then I also just asked them, just go up the stairs and see how you do and see how you feel over time and keep a diary of your exercise tolerance. So some additional guidance. Ooh, okay. Sometimes we make additional recommendations. So if you're somebody who's like almost there but not quite, I may just tell you, it's okay to dive in certain areas of the world. Cozumel's good. There's actually decent medical care there. Definitely no Rajan Pot, no Socorro, not the Caribbean, because you want to be in places where you can get medical care if something goes down. And a lot of the tropical destinations actually don't have decent medical care available, surprisingly. I may tell you just, avoid additional decompression stress. Don't do anything that requires anything near decompression. No Socorro. And then we have the issue of emergency medical care. So this is the DAN map, and the green locations are 24/7, yellow is maybe. It's compressed into a small picture, so it looks like there's a lot of 24/7 locations. There's not.
Yeah.
So across the US, in 2020, there were about 65 or so emergency hyperbaric facilities across the US. That number goes down by about 10 each year. Emergency hyperbarics is not financially beneficial for hospitals because you're keeping people on call to treat people that are very infrequent in number. So it's something that doesn't make hospitals money. Hospitals lose money on it, a lot. I used to work at a 24/7 place, and it is no longer in business because it was losing money like crazy for the hospital. So if you have questions, it's always good to call Dan. Dan always has the most up-to-date information on emergency medical care. So Hawaii, for example, they have one 24/7 chamber. It's on Oahu, and it goes down for maintenance for a long time each year. So that means if you get in trouble in Hawaii, you're going to get medevaced out to the mainland, to San Diego. So it's always good to check before you go to know what's available. So now we'll segue into what is hyperbarics. So this is what I do with the hospital. So these are all some Google pictures of hyperbarics, but really, that's one of my kids. Really, there's only 2 that are hyperbarics. So hyperbarics involves breathing oxygen. You have to actually breathe it while the treatment vessel is pressurized greater than sea level. So you can't just have a box on your foot or something like that. Somebody was asking me about this today. Yeah, you have to breathe it. This is all hokey stuff. This stuff is a little cray-cray too. So this is what the professional athletes use. So they even, including the teams in this area, they have these fabric chambers, and people have them in their homes too. Fabric, it's fabric. It's malleable. It doesn't really hold pressure that well, so you can't really apply high pressures to fabric chambers. And so this is more of a placebo effect than anything. So we don't want to play those games. Yeah, but he's not a regular.
He's left in a regular.
Yeah, and so now the young people know it because Justin Bieber sleeps in one. Yeah.
Yeah, he has some weird.
He has some weird thing like Lyme or something, like chronic Lyme. Yeah. And then.
And it had some sort of
palsy.
palsy.
He had Bell's palsy. Yeah,
well.
I think he might have been doing it for his bowels, actually.
That's what I think he was doing.
And I think I have a slide up a little bit more about what you see on TV, in popular media. It's funny how the media portrays hyperbarics. It's either something that's great or it's a torture device. So we use it for lots of different things. I mean, obviously for decompression illness, air embolus. So really, really bad decompression illness when the air bubbles go up into your brain. That's called an air embolus. That is bad. That will kill you if you don't get hyperbarics ASAP. And then we use it for some wound conditions too. So in the hospital setting, generally hospitals use hyperbarics to treat wounds because those patients come in every day and you can bill insurance for it, so hospitals can make money off of it. If you're using it to treat decompression sickness, you might get one patient every 6 months or something. So again, it's not really financially viable for most hospitals.
How does it improve, this is just my lack of science knowledge, but how does more oxygen improve a wound?
So if you have a chronic wound, all chronic wounds by definition lack oxygen. It's just how it is. So if you put a bunch of oxygen into the bloodstream down by the wound, that there's like a gradient between all the oxygen going into the wound and the wound that doesn't have oxygen, that actually stimulates blood vessel growth. So it actually helps heal wounds that way. It doesn't work right away. It takes about a month to happen, but it does work. I don't think I put any wound pictures on here because they're kind of gross. I don't want to gross you guys out. But it works really well. So we use it to treat, like right now I've got people that had, somebody had a melanoma taken off their leg last week and it turned dusky, it turned necrotic, so we're gonna start them tomorrow. People have mastectomies that turn necrotic. People that have diabetic foot wounds. Yeah, all sorts of different wounds can do great. I got a guy that's actually in the hospital right now. He had like just random like hammer toe surgery last week and his like middle toe turned black on his like left foot. So yeah, I was actually calling on my way over here. My husband's on call tonight at Hospital Center. And I was like, hey, check to see if this guy's still in the hospital. He's still there. I may not see him Wednesday. So this is my slide about like all the public perceptions. I think this like cracks me up. So the Real Housewives of Beverly Hills, this was probably like 6 or 7 years ago now. So Yolanda Foster was married to David Foster back in the 80s, and he was that composer for like, he did like You're the Inspiration, like all these famous songs. Yeah. So all the young people know her because she's on the show, and she's the mother of the supermodels Gigi and Bella Hadid. So she was on the show, and she did hyperbarics because she has chronic Lyme, which is totally like not scientifically proven to be treated by hyperbarics, but she did it, whatever. So she looks like she's having fun, like she's giving a thumbs up, and she's wearing her street clothes, and she looks happy. And then in Deadpool, we have Ryan Reynolds being tortured in a hyperbaric chamber, and Shannon Doherty from 90210. So she actually went in one. That was on Instagram a couple years ago. She had breast cancer.
She had stage 4 breast cancer.
Yeah. So I think this was during one of her initial surgeries, and so she had it for healing. So it looks, she looks like she's chilling out, like nothing could go wrong. It's all like good, whatevs. But the problem is that every rose has its thorn, child of the 80s. So we always have to be careful because badness can happen. So when we're doing hyperbarics, we only want to do it for things where there's actually medical evidence to use it for, because it does have its risks. So people think that they can do it because it's not risky because we're breathing oxygen right now in the air that we breathe, right? But what is the oxygen concentration that we're breathing right now? 21%, and in the hyperbaric chamber you're getting 100%. So the physiology of oxygen is very different at 21% versus 100%, right? So that's what we have to be concerned about. And you can have bad stuff happen. So this is an example. This is a random hyperbaric facility in Florida. It's actually still in business. You can't really see it too well, but they're little marquee sign that says that they treat like stroke and near drowning and all sorts of that stuff. And that's not good because there's an ambulance like got somebody on a stretcher.
Like that's basically like a sidewalk clinic.
Yeah. And they have them out here. Yes, and they have them in this area. There's one in Reston. It's right across the street from Reston Hospital, and people think that it's totally legit. There's one in Vienna where they actually have a puppy mill there. I've heard from several patients that they went there and there's like puppies back there. And then there used to be one in Bethesda. I'm not sure if it's still in existence, but when I first moved here, it was there. So they're around.
Your medical facility has puppies.
Well, one would think, but it's cheap and they're friendly, and they'll probably if you have Kaiser, they'll bring you in. So unlike me, I'll be like, I don't take your Kaiser, and I'm like, oh, I'm going to go to the other place. So they frequently run on these like very small profit margins, and so they have to use really old equipment. So this was the chamber that they used in Florida, and it looks like a coffin. Wow. This was from the 1960s, and nobody does maintenance on these anymore, and they couldn't find anyone to maintenance it, and they didn't really know how to maintenance it. So they just falsified the records. They still used it. They made up some records. Nothing could go wrong. So these chambers are meant to hold one person. They're called a monoplace chamber. This is what we have at Georgetown, but they don't look like that. You don't put two people in a single person chamber. Like you just don't. It's like basically against fire code, first of all. But they did, and they put in a 4-year-old boy and his grandmother who came over from Italy to treat his autism. and they let them wear their street clothes in. I mean, my street clothes are very comfortable, but this is synthetic fabric.
Yeah.
And synthetic fabric under fire, it burns.
Yeah.
Like, I mean, this has been studied, like,
Yeah.
cotton burns the least, but anything else is gonna burn avidly. And that's what happens in, you know, on airplanes when there's fires, and then like in all like the space flights where there are fires, like, yeah, it's very basic fire safety stuff. So they didn't follow it. They let the kid go in with his grandmother. They let them wear their street clothes. The grandmother had some alcohol wipes in their pocket. They had falsified the maintenance records, so they didn't have the great chamber. There was a spark, and then they both died. So.
Oh my God.
So that's the chamber aftermath, and that is not survivable. So we know by definition that a fire in a single person hyperbaric chamber, you're gonna die, 100% chance of death. So in the hospital setting, we're really careful about fire safety. This is another example. This is an equine chamber, also in Florida. These actually happened in the same year. So this was, they put horses in hyperbaric chambers to like condition them before their races. And this horse they normally sedated, but on this day they didn't. And so the horse got in the chamber and kind of like wigged out and kicked the side of the chamber, and there was a spark, and then the chamber exploded. So that's what it looked like after the fact. So the horse died and the trainer died, and that is not good. So these were the fatalities that happened in the U.S. They've also happened overseas. There was a big one in Italy. I think there was one in Mexico recently. So they do happen. It's easy to prevent though. If you just are very simple and follow very strict fire safety measures, you're not going to have a fire. So in a hospital in the U.S., there's never been a fatal hyperbaric fire, but we're very careful. So we don't let you take in foreign objects. You can't bring in your cell phone because like the lithium battery. You can't bring in like whatever, like your hearing aids that have batteries in them. Anything that's battery powered is going to be a fire hazard. Anything that burns. So your synthetic fabrics, your underwear, even like the waistbands are synthetic. So we don't allow any of that. There's actually a fire safety code called NFPA 99. It's the Healthcare Facility Fire Safety Code. So the fire marshal can come into any hospital any day and be like, yo, I want to see how you're following NFPA 99. Hyperbarics actually has its own chapter in the NFPA handbook just because it's such a fire sensitive environment. So we don't allow certain things in the chamber. Every chamber in the US in a hospital should have a sign like that or something similar up that talks about what you can bring in and what you can't bring in. But we don't allow any like hairspray, makeup, lotion, deodorant, synthetic fabrics, like anything like that. Anything that could potentially spark or fuel a fire does not go in our chamber.
Hair gel.
Hair gel. Oh my goodness. In the last month, I've had 2 women that have like eyelash extensions.
Oh yeah, the glue.
Oh, the glue cannot go in.
Exactly. I can totally see that. Oh.
And they don't want to take them off.
Yeah. Oh.
Like, I've got a girl that, I saw somebody on Friday. She's like, I don't want to take these off. I'm like, they gotta come off, girl. Like,
They're gonna burn your eyes.
Yeah, we are not having that. I actually have to call about her now that I think of it because she's starting tomorrow. I gotta make sure that she got those extensions taken off. The hair extensions are also a problem.
Yeah,
nail polish is a problem. Yeah. So you pretty much come in like au naturel.
Yeah.
Yeah, you just shower and come on in. Like, we don't judge. We know, we expect that people are just gonna be like not looking great, but that's how it is. So recently, people have looked at using hyperbarics for long COVID. And this really started overseas, and it's sort of grown in interest in the US. We don't really know why, but there's some suggestion that the oxygenation that hyperbarics gives may actually affect the brain damage. So it's been mostly investigated for people who have like brain fog and fatigue and stuff like that from COVID. Some people think that and we see this, we treat Jehovah's Witnesses too. When you put somebody at a high pressure and then bring them to a low pressure, so we decompress them, your body goes in and out of hyperoxygenation, and that can actually stimulate blood cell production. So if you're a Jehovah's Witness and you're anemic, we treat a lot of them. They're great, they do great. And the same thing might happen with COVID also. There's my other son. They're just like checking me out.
They're like, all right, Mom.
The ball game must be boring. So people always call and ask about using hyperbarics for long COVID, and actually I got a call today from one of the med-surg hospitals in Baltimore. A lot of patients know about it. There was one article that came out recently from overseas that was, it was like open access so anybody can read it. So people saw that and thought that, you know, they could get hyperbaric for long COVID, which is great, except that there's not a lot of literature from the US. And so because of that, US insurance companies are not too keen on covering it. The studies all had different like outcome measures, and they used different numbers of treatments, like anywhere from like 10 to 60 treatments, I think. So it's not really standardized literature, but in the studies, people had improvements of their brain function, their fatigue, and their overall quality of life. So there is some suggestion that maybe it does have a benefit. So I made a little graph of all the studies, and the most important thing is just like that third column. It talks about the number of subjects, very low numbers. Like one only had one person in it. You know, the one below it had 73. That was the biggest one. But we're not seeing, it's not like 10,000 people were studied. And this is one of the reasons that insurance companies are sort of hesitant to cover it. The treatment depths are all different. The number of treatments varies from like 10 to 60 or 85 days. So it's sort of all over the place, but again, they are reporting some improvements.
If you were to, I mean, I presume you aren't designing a study to do this, but like you have this guy with brain fog, if you were to have the opportunity to give him time in one of these, in the chamber, what would be your gut? Would you say, I think you should probably do this 5 times over a period of X amount of time?
Yeah, so I'm treating him actually, and I'll explain how I got him covered by insurance, but I put him at the protocol used in that 73-person study, so 2.0 for 90 minutes for 40 treatments. So yeah, that's what if I can get insurance off, I'm using that because that's the best data. So that one, I didn't list it on there, but they actually, it was prospective. They actually had a sham chamber, so they pressurized people in a placebo group enough to equalize their ears, which is key because then they're blinded and they feel it and they feel like they're getting something. So the best hyperbaric studies have that sham group where they like make you equalize your ears. Yeah. Would what? I'm sorry? Ozone is actually really dangerous. So ozone involves, it's usually injection of ozone into the body, and that actually can cause air emboli. That can cause air embolism. The ozone breaks apart in your body, and the oxygen-free radical can go to your brain and cause an air embolism. Yeah, so we don't want to do ozone. But yeah, so my protocol for my one patient that I've gotten covered for this is the 2.0 for 40 treatments. Again, it's hard to get insurance to cover it.
So he's
doing
40. Do you do it once a week? Do you do it 5
Monday
times?
through Friday.
So
8 weeks.
So it's 8
yeah,
weeks.
8 weeks, no weekends, no holidays, but Monday through Friday otherwise. So yeah, so he got approved for 40. I mean, it took me 2 months to get him approved, but he's approved. I'm sorry?
How long do you treat?
2 hours.
2 hours.
Yeah. Yeah, so it's pretty much, it's like a square dive, so it's a 10-minute compression, 90 minutes at 100% oxygen, and then you decompress over 10 minutes as well. Yeah, and then in this one they actually did, I'm pretty sure they gave air breaks. So when you go below 2.0, you're actually at higher risk for oxygen toxicity seizures. So you have to breathe air every half hour, just compressed air through a mask. And I'm pretty sure, if I remember correctly, that's what they did in that 73-person study. So that's what I'm doing for him too. So yeah, so it's just a straight square 120-minute dive.
So what do you do for 2 hours?
You watch a movie or you go to sleep because you can't bring anything in there with you. So our chambers all have a TV monitor on top of them, much smaller than that one. More like this size. We're not too fancy at Georgetown. I've heard that Virginia Hospital Center has Netflix. We don't have any of that. We're poor at Georgetown. We need a benefactor, but we play DVDs. And so we've got like a whole wall of them, or some of our patients just bring in their own, and they just watch. They go through like Law and Order or like whatever, and they just watch that, or they take a nap.
Binge.
Yeah, they do. They binge their TV shows, and it's sort of like their personal time, so they don't have to worry about work or school or life. You just go in there and hang out. Yeah, they wear like little robes that we give them. So we get a lot of calls from people that want hyperbarics for all sorts of things, and a very common comment is, I have good insurance. And I'm like, I bet you do have good insurance, but it won't cover hyperbarics for X, Y, or Z. So we're going to do a quick review of insurance policies. So most insurance policies will publish a medical policy bulletin that details exactly what they cover and what they don't cover. The reason they do this is because hyperbarics is very costly. So if you come into Georgetown and you call me and you say, I stubbed my pinky toe last week, I want hyperbarics, you're gonna pay $4,000 per treatment. I'm not getting the money. The hospital's taking about $3,800 of that. The physician fee's like $300 per treatment. The hospital's making like bank off of that. And you know, I mean, you can go online and read about all the facility fees and how they're upcharged and all that stuff, and it's totally true. I don't know that oxygen's worth like $3,800, but to Georgetown it is. So pretty much any hospital you're going to pay that much. And so if you're coming in for like 20 or 40 treatments, it's like $100,000, $150,000. So insurance companies are aware that hyperbarics in the past has been overutilized, and so they're pretty restrictive on what they'll cover. So this is Care First, and they basically give their little medically necessary diagnoses, and there's not that many. Everything below, did I highlight it? Yeah, everything that below the X is not covered. So there's only about like 10 or 15 diagnoses that they cover. And they're pretty standard for every carrier. There's a little bit of variation. You know, I can get certain things covered by Cigna that Care First won't cover, and you know, there's Federal Blue Cross is actually the worst, paradoxically, for hyperbarics. They cover very few things. They're the most restrictive. But for the most part, the diagnoses are mostly the same. Here's Federal Blue Cross. Okay, so Federal Blue Cross, extremely restrictive. I think I highlighted, yeah, so that is their medically necessary section, and then they have like 3 pages of everything that's not medically necessary. So very restrictive. You cannot deviate from the policy. You actually can, but you have to jump through a lot of hoops, and most doctors don't want to do that. However, with COVID, being that it was a public health emergency, like about 6 months ago, I was talking with somebody, I was doing some sort of medical review at Federal Blue Cross, and I talked to one of the medical directors, and he was like, yeah, it's a public health emergency, so we were told to be very lenient with our COVID coverage. So it took me 2 months, but I was able to get that one guy with Federal Blue Cross covered for hyperbarics for 40 treatments by Federal Blue Cross. It was amazing. The public health emergency ends next week, so if you all who have Federal Blue Cross want to get hyperbarics for COVID, you better do it the next 10 days, because I don't think that Federal Blue Cross is going to be quite so lenient after that. But they approved my guy through like August or something. So, I mean, they didn't cut him off on May 11th when the public health emergency ends. So I was happy about that. But with the other carriers, like with Cigna and Aetna and all of those, like, we can't get it covered. I've tried with no luck. So yeah, diagnoses that don't meet medical policy guidelines will not be covered. You'll end up getting a big bill. You'll be self-pay. It's not going to be fun. So that's why we.
It did look like decompression sickness was.
So you know what's really weird? So the big 3 that everyone covers are going to be, well, decompression sickness, air embolus, and carbon monoxide poisoning. And those are usually at the top. I don't have, like, Cigna is a good example. I didn't put Cigna up, but Cigna breaks it down into, like, these diagnoses are first-line medically necessary therapies, and then everything else is adjunctive, like we cover it, but you should do other stuff too. Like if you have an infection in your foot, you need antibiotics. But it's first-line therapy for those 3. So Cigna also includes anemia. If you can't get a blood transfusion, they include anemia out there. They must use that like upper box so infrequently that they don't even know what it is. Like I've had to call Cigna and like walk their medical directors through the policy. And they're like, we don't see anemia on here. We don't cover anemia. And I'm like, oh no, it's right up there with decompression sickness. So the moral of that story is if you have decompression sickness, you still have to get a prior authorization, because the Cigna people or the insurance people may not recognize that it's on the policy, because they're so used to see diabetic foot wounds. And because that's what like most hyperbaric centers treat. You know, I've also had, I think Aetna. I had a case with Aetna where I had somebody who had decompression sickness, and Aetna still required like regular prior auth. Like I had to go through like the whole process. And I'm like, this is time sensitive. I need to get this person in like today, not like in 2 weeks. So it's a lot of phone calls. But yeah, they all cover decompression sickness. It's not as simple as one might think. So we talked about that. Oh yeah, our hospital CFO may discount by 20%, but they don't give like big discounts, unfortunately. This is important, actually. So everything's cheaper in Maryland. So I don't know why, it's just how the insurance
Because we're
reimbursement
low
is.
rent over there.
You're low rent. Everything is cheaper. Yeah, it's negotiated rates. So the hospital gets like a set amount for each patient, and that's what they can spend. So they can't be like billing $4,000 for treatment, because they're only gonna get like, $159. So everything is cheaper in Maryland. I have sent so many people to Maryland hospitals for hyperbarics, because it's like self-pay is like $1,000 there.